I will present about the anatomical consideration in upper cervical instrumentation, and please give me advice after this presentation. This is case, male 14 years old, fall down with tetraparesis UN type, and you see this MRI. So the treatment, it will be realignment, decompression, stabilization with implant. We know that upper cervical anatomy, it is complexity, anatomical structure, many important structure, planus venosus, C1, C2, CO bone, and limited bone stock on there, and also suboccipital space is narrow. And we know that in the C1 lateral mass, there are many techniques, nearly same. And we know that in the trajectory of C1 lateral mass screw is like this. We can purchase more band stock here. We have studied about the C1 morphometry in our population, Indonesian. We have lateral mass thickness is from 8 to 12, and lateral mass inclination in vertical is 18. Of course, intraoperatively we can see purchase at this point, no problem. And from the horizontal is from 16 to 20, and we have this is 8 to 12 thickness, and our screw is 3.58, means we have big bone here actually. But there is a complication of C1 lateral mass screw if we perforation of O, CO, and C1 joint. And this is we among at this point. And even if you know the anatomy better, we can make it a freehand technique. And in the C1 lateral mass screw, it may be significant bleeding from the venous planoxus, and sometimes it's very massive and become hypotension. So we must do periosteum dissection. So we peel the venous planoxus, plexus venosus, and sometimes it may make a C2 root irritation. We can insert through the posterior arch here the screw, and this is an option. And this is the arch screw. The bone, we can purchase the bone longer than the lateral mass screw. But we must aware about ponticulus posticus. In Korea, there are many, but for Indonesian people, since now I have met this ponticulus posticus. Ponticulus posticus may be mistaken for the broad approach to the arch, and may be mistaken for this is the arch, so it may injure the artery vertebralis. And ponticulus posticus is not uncommon. There are so many variations in size and shape. So make a CT scan and study about the ponticulus posticus is mandatory in this area. And after, this is the ponticulus posticus. After we resect, we can put the screw here. And this is the other technique of percutaneous transarticular C1, C2 screw fixation. Of course, we know. And about C2 pedicle screw, there are also many techniques here with a little bit difference in medial, how much and how many degree we must aiming the medial. But in our population, that the pedicle length is usually 24, and pedicle diameter is 10. This is, and aiming is 13 to 20 degree medially. The high riding vertebral artery is maybe 10 to 20 of from normal population, according to the new criteria. And if it is happen, it is maybe difficult to put the screw there, like this one. Almost impossible to put screw here. So maybe we can put it in the laminar screw. Laminar length is 36 millimeter. This is long enough, strong enough. And the laminar weight is 6 to 7 millimeter. And this is big enough for our screw, 3.5 millimeter. So this is the laminar screw. Laminar screw. This is laminar screw, like this, and this is laminar screw. So back to the case that maybe the option may be like this, but maybe we can put it in the short segment to do realignment, decompression, and stabilization without C1 arcs resection. And this is the other case that spondylitis tibiae, and it is a kyphosis, and we must to realign to become lordotic. And this is the other case that a female 60 years old motorcycle accident, neck pain, ACIA, and we saw that this burst fracture C2, and what we did is C1 lateral screw and C2 lamina screw here as a cantilever, and we destruct this one with the C3 lateral mass as the basis of the construct. This is 51 years old male with OPLL, very narrow here, and of course we need posterior decompression and fusion instrumentation, but there's a left high riding vertebral artery. So I think I tried to put screw here, direct, straight here, and I found that we can purchase 20 millimeter along the bone. It is, I think, quite enough. And this is the other. My second case is we have case like that. Actually, I have no CT scan here, but when I saw this is the canal, and then one slice after the canal, there are left, right, high riding vertebral artery. So I choose to make put it screw here, like this, and just straight like that. And it was 18 millimeter, and I put 20 screw, 20 millimeter to 2 millimeter to make it free of the head of the screw. And this is the screw in the left side. So as the conclusion is C1, C2 instrumentation are safe if we understand the individual anatomy of the patient. And as the recommendation, we must should do a pre-op CT scan study. Tasyakur hadirin.
Any questions? Yes, please.
Lectures. I would like to ask you about the cases of OPLL.
Yeah.
Is it, do you think it's necessary or essential to add the instrumentation, or the disease itself is fixing the spine?
It was not fixed OPLF. We did flexion extension, and it was mobile.
Thank you.
Yes, Dr. Asakar.
Just a technical question. When you go for C1 lateral mass, you always cut C2 root? No.
Okay. Thank you, Dr. Echo. Okay, please.
Yeah, just one adding. Actually, it was very nice to show, especially a high-riding vertebral artery. The possibility of injuring the vertebral artery, it's been said, is about 20% in C1, C2 transarticular screwing. For that reason, because the other techniques are more safe, so then I left using C1, C2 transarticular screwing. I don't do it now.
Okay. Thank you, Dr. Echo. Now we move to the next